Hi everyone, today I'll be demonstrating manual muscle testing focusing on the lumbopelvic complex, an area crucial for postural control, movement efficiency, and prevention of lower back pain. To begin, let's consider a brief case example. My client is a 25-year-old recreational runner and touch football player. There's no acute injury, but she spends long hours sitting for work and has recently increased her running load. The goal today is to assess her lumbopelvic stability and strength using manual muscle testing across 3 lower limb joints, the hip, knee, and ankle. Before starting, I'll remind my client about safety. There will be no abrupt or excessive forces. We'll remain within comfortable joint ranges, and I'll check for any discomfort throughout. Do you give consent to having these manual muscle tests? Mm-hmm. Awesome. Now for the setup and warm-up. To prepare, we'll start with a light dynamic warm-up to increase circulation and activate the key stabilizing muscles. So let's begin with some pelvic tilts. Can you please jump on your back in supine position. That's it. And just lift your pelvis up a little bit. Yep, leaving your glutes grounded. That's it, like rocking the boat. It's not a good instruction, is it? Now we can transition into some hip thrusts. That's it, and you can bring up, into complete extension. Good hip extension, with no assistance from the hands on the sides. Awesome, now we're going to progress into cat-cow stretches. So can you please jump into this position on your knees, and then bring your hands forward at shoulder width. That's it. And then go into lumbar extension through here and flexion. Yep. That's it. Look high to the sky when you're in lumbar extension. For thoracic release. Awesome, in our last transition, we're going to go into bird dog holds to lightly engage the transverse abdominis and multifidus, both vital for lumbopelvic stability. So what we're going to do here is, while you're in this position, you can lift your right arm and left leg at the same time, keeping them as straight as possible, yes? And then transversely with your left arm and right leg. We could do 5 on each side. Number 2, number 2, number 3, number 3, number 4, number 4, number 5, number 5. Awesome job. Now we're going to move on to the 3 muscle tests spread across 3 different joints, starting with the hip joint connected to the gluteus maximus. The function of the gluteus maximus is hip extension and external rotation, as it is a major stabilizer in gait and posture. For the positioning, the client is prone with knee flexed to 90 degrees. So can you please flex your knee to 90 degrees? Thank you. I stabilize the pelvis with one hand and apply resistance to the distal femur in the direction of hip flexion. So can you please lift your thigh off the table and hold? Thank you. So what we found there was hamstring dominance, as it was firing much more than the lumbar. Strong contraction with minimal compensation indicates good posterior chain activation, where weakness or delayed firing may indicate poor gluteal recruitment. common in sedentary individuals or those with lower back discomfort. Now we will move on to the ankle joint, specifically the gastrocnemius. We measure the gastrocnemius in extension as it crosses over the knee and ankle joint. The function is plantar flexion, contributing to propulsion and stability during gait. For the positioning, the client will remain prone with foot hanging off the table. I will stabilize the distal leg and apply pressure on the plantar surface of the forefoot during dorsiflexion. Can you please push your foot as if you were pushing a pedal? Awesome, thank you. That was really good plantar flexion recruitment. Full resistance indicates strong plantar flexors. Reduced response could impair stability and shock absorption through the lumbopelvic chain. Now we will move on to the knee joint, more specifically the quadriceps femoris muscle. The function is knee extension and shock absorption during the stance phase. For the positioning, the client will be seated with knee flexed at 90 degrees. So could you please sit on the bench for me? That's it, and get that knee flexed at 90 degrees. I will stabilize the thigh and apply resistance at the distal tibia in the direction of flexion. Can you straighten your knee and hold, please? Thank you. Symmetrical strength bilaterally indicates balanced lower limb control. Asymmetry could contribute to pelvic tilt or gait imbalance. Now that we've tested across the hip, knee and ankle, I'll interpret the findings as a whole. A strong and symmetrical response across all three joints would suggest functional kinetic chain integrity. However, a weak or delayed response at one joint, for example, gluteal inhibition, can alter pelvic mechanics, leading to compensatory loading in the lumbar spine. Other influences to consider include fatigue, motivation, technique, and tester error, which all may affect results. So it's essential to retest if unsure and always correlate findings with functional movement assessment. To summarize, manual muscle testing is a valuable clinical tool for assessing strength, symmetry, and neuromuscular control within the lumbopelvic region. In this case, our findings may guide us toward targeted strengthening for the gluteal complex and core stabilizers, alongside flexibility and endurance work to support long-term spinal health. Ultimately, effective assessment informs safe, evidence-based exercise prescription and helps clients like this return to pain-free, efficient movement. For subtask 2, I'll be presenting findings from the allocated worksheet, the lumbopelvic complex, focusing on one global muscle assessment, the plank test, while discussing findings from the other assessments. Before discussing my findings, I'd like to briefly explain the rationale. The lumbopelvic complex forms the foundation for movement and stability between the upper and lower body. Weakness or poor endurance in this area is often associated with chronic, non-specific low back pain, as highlighted in the literature. Contributing factors can include weak global trunk muscles, including flexors, extensors, and lateral stabilizers, poor lumbopelvic control or postural stability, weak hip extensors, and poor movement efficiency and endurance deficits. Lastly, we will choose a muscle test from the lumbopelvic complex. We have chosen the plank test. The purpose is to assess trunk flexor endurance under sustained load. For the procedure, my client will assume the forearm plank position. So with your elbows beneath your shoulders, a neutral spine, and toes out. That's it. Neutral spine, bring the glutes down a bit. And now your elbows below your shoulders. There you go. Forearms down. That's it. Now we can start. Try and avoid lumbar sag. That's it. Stay with it. Normative endurance for females, as reported, is approximately between 63 and 83 seconds, while participants with mechanical low back pain average around 28 seconds. Therefore, my client's time of 45 seconds indicates below average endurance relative to healthy norms, but above the threshold commonly seen in individuals with symptomatic low back pain. This suggests a moderate endurance capacity with early fatigue in the anterior trunk stabilizers, particularly the deep stabilizers such as the transverse abdominals and internal obliques. The observed lumbar sag indicates a shift of load to the lumbar extensors and a reduced ability to maintain intra-abdominal pressure. Starting with the lumbopelvic stability test, I assessed activation of the deep stabilizing muscles, the transversus abdominis and multifidus in crook lying. After initial breath holding, the client was able to isolate and maintain deep core activation while performing alternating leg lifts, which indicates she reached stage 3 stability. This demonstrates sufficient local stabilizer control to safely progress to global muscle testing, though the mild delay in activation suggests some habitual inhibition from prolonged sitting and running load. Next was the 7-stage sit-up test, which assesses global trunk flexor strength. The client completed stages 1 through 4 with correct form, but was unable to progress to stage 5 without momentum or hip lift. Achieving stage 4 indicates below average global abdominal strength for her demographic. This suggests underdeveloped rectus abdominis and oblique endurance relative to her physical activity level. Such deficits can reduce trunk stability during prolonged dynamic movement, potentially contributing to lumbopelvic fatigue and lower back strain. Moving on to the prone hip extensor activation test, the client showed hamstring dominance on the left side and more optimal gluteal activation on the right. This asymmetry suggests mild left gluteal inhibition, which is common in individuals with increased running volume or prolonged sitting. Gluteal underactivation can lead to poor pelvic stabilization and compensatory lower back loading during activity. For the supported trunk extensor range of motion, the client achieved full pain-free lumbar extension with gluteal contraction maintained and no hip lift from the mat. The measured acromion height from the floor was 22 centimeters, indicating healthy spinal mobility with only mild stiffness at end range, likely from recent increases in training load rather than structural restriction. Finally, I performed the trunk extensor endurance test. The client maintained the prone hold for 105 seconds, which falls slightly below the normative average of 130 seconds for females. This suggests moderate endurance of the posterior chain, but some fatigue in the trunk extensors. Given her sport participation and running frequency, this may indicate the need for greater posterior chain conditioning, particularly targeting the erector spinae and gluteus maximus. I will now integrate the tests of the subtask 1. Beginning with the hip joint, connecting to the gluteus maximus. The result was a hamstring dominant pattern during prone hip extension. The interpretation is indicating mild gluteal inhibition and delayed activation,
common in individuals with prolonged sitting or increased running load. And the relevance is reduced gluteal contribution can compromise pelvic alignment and increase lumbar extensor workload consistent with the fatigue seen in the plank test. For the knee joint and the quadriceps femoris, the result was strong symmetrical extension bilaterally with an interpretation of adequate knee extensor strength supporting lower limb control but not appearing to offset proximal instability at the pelvis. For the ankle joint and the gastrocnemius muscle, the result was strong symmetrical bilateral plantar flexion with an interpretation of effective distal strength and propulsion mechanics unlikely to contribute to lumbar pelvic dysfunction. Taken together, these findings indicate adequate distal and mid-limb strength found in the quadriceps and gastrocnemius, mild proximal weakness and endurance limitation in the core stabilizers, and delayed gluteal activation contributing to posterior chain imbalance. The 45-second plank result highlights early core fatigue, potentially caused by an over-reliance on global trunk muscles and insufficient endurance of the local stabilizing system. These characteristics may predispose the client to lower back fatigue, especially during longer runs or multi-directional sport movements. Based on these results, my recommendations would be core endurance retraining, focusing on low load, deep stabilizer activation, such as transverse abdominis draw-in maneuvers and dead bug variations before progressing to dynamic planks. Gluteal activation exercises would also be a great recommendation, including bridges, hip thrusts, and prone hip extensions with tactile feedback to correct hamstring dominance. And lastly, progressive integration into compound movements to enhance neuromuscular coordination and reduce load transfer to the lumbar spine. In conclusion, my client's plank result of 45-second indicates below average endurance and mild compensatory lumbar activation, consistent with weak, deep stabilizers and gluteal under-recruitment. When considered alongside strong distal limb strength, but reduced proximal control, the findings suggest the need for a targeted core and posterior chain conditioning program to enhance lumbopelvic stability and prevent chronic lower back discomfort. These results provide a clear, evidence-based foundation for safe exercise prescription and progress monitoring.